Great. So I'm going to be talking about CAR T therapy. That's chimeric antigen receptor T cell therapy for autoimmune disease, with a particular focus, obviously, today on how this is being utilized and explored in multiple sclerosis. Before I dive into what is CAR T, I think it's always helpful to just have a perspective of what is the immune system? How do these immune cells function before we dive into a therapy that changes your T cells? So your immune system is your mobile defense system. You have many cells, as you can see here on this slide, circulating in the blood, not just red blood cells, but all these smattering of white blood cells that are part of this defense system. You also have proteins that travel through the blood, including antibodies and cytokines that help activate these cells. Now, the immune system is really there as our defense against infection and disease. And when I say disease, that includes cancer, which I'll get to in a bit. So looking at all of these types of white blood cells or immune cells in the blood, you can see that there are many. However, the focus today is going to be right here in this circle, your T cells and your B cells. Your B cells are those cells that make antibodies. Now, taking a step back, how does the immune system work? When I talk about B cells and T cells, I'm talking about your adaptive immune system. So this is part of the immune system that has to learn. So your B and T cells undergo a learning process so they don't become misbehaving or bad or autoreactive, meaning they're not attacking things they shouldn't be attacking. For instance, as you can see on this little cartoon of a neuron in the brain, that nice coating around the axon part of the nerve here is called myelin, and I think a lot of people have heard about myelin because that is essential in the disease process for multiple sclerosis. So you want your T cells and your B cells not to recognize myelin, because when that happens, it causes autoimmune disease or autoreactivity. So all of these cells you produce hundreds and thousands of immune cells, actually billions of immune cells in the bone marrow. And these immune cells go to the thymus gland and basically learn not to attack the body. Unfortunately, as you can see in the cartoon here, you have some bad students in red where they don't learn properly. They're not supposed to get out of the thymus, but they do. And when they do, if they cross over into the brain, you can see they cause destruction of the myelin. So focusing first on these B cells are there to, in a normal functioning immune system, activate antibodies against environmental things like a virus. So you have a virus here, you have a B cell that recognizes this virus and produces antibodies. That the antibodies attack the virus, surround it, and with the help of the rest of the immune system, clear it out. T cells recognize and kill these infected cells. So once you have an infected cell, you can get this receptor or T cell receptor on that infected cell that basically signals the killer T cell to get rid of it and kill it. So what about CAR T therapy? Well, these T cells can be engineered or made to seek out a target because of these signals that we use. So CAR T therapy was first utilized in leukemias and lymphomas, so blood cancers, where they would take an individual's own T cell, engineer it in a lab, make it so you can give that back to a patient and use their own immune system, their own T cell, to destroy cancer cells. And so the way this gets reprogrammed is we use a viral vector. In the lab, these T cells undergo a change, and you can see here, all the way on the right, we kind of have this army man ready to take out the bad cells. So like I said, this process was first used in cancer. Again, you can use these T cells. They can be made in the lab using your own T cells to recognize and kill these cancer cells with this reprogramming. But now this is crossing over into autoimmune disease, and you can use these T cells to recognize and kill target cells that are misbehaving immune cells. So for an example here, instead of, the normal process of an infected cell getting recognized and destroyed, you can engineer this CAR T against a misbehaving B cell, and a misbehaving B cell is one of those B cells that's making antibody, for example, causing an autoimmune disease and causing destruction of the nervous system. So you can use this CAR T to target part of that B cell to destroy it and get rid of it. So this is something that's being explored not only for multiple sclerosis, but for many autoimmune diseases. This is a recent publication just this year that looked at 15 patients with rheumatologic disease, including lupus, myositis, which is inflammation of the muscle, systemic sclerosis, which is a terrible rheumatologic disease that causes hardening of the skin. And just using a single infusion of an anti-CD19 T cell target, they followed patients up to 2 years, and there was a fairly good response without the need of ongoing disease-modifying therapy in these diseases. Importantly, they also saw a low relative side effect profile. There are definitely a lot of side effects, and I'm going to get into that on the last slide when I talk about what does this process look like for a patient. However, in this paper, they looked at mainly grade 1 and grade 2 cytokine release syndrome side effects. Cytokine release syndrome, you can think about when those B cells are destroyed, they spew out all the contents of what's in that B cell, which is a lot of proteins that cause inflammation, including cytokines, and that's where you get the cytokine release. And that causes, in the short term, a lot of inflammation when those B cells are dying. And just a plug, because I can't get away, even though this is focused on MS, we do have a clinical trial that we're looking at not only MS, but stiff person syndrome here on campus. So I just had to put that plug in because, I can't not do that. So why are we looking at CAR T therapy in MS? It's very clear, and you've heard, through the years, a ton of updates. We have all these wonderful therapies for disease-modifying therapies in multiple sclerosis that are approved. So why push that envelope, especially when we know this process comes with, a lot of side effects? Well, I think there are limitations to what we have today, even on this timeline, and some things that you've already heard about today. There is still progression that we can see despite the use of disease-modifying therapies, and some of this is due to that smoldering kind of ongoing inflammation. These medications on this timeline here, I'm going to focus on the highly efficacious therapies. Look at those ones that end in MAB. That's a monoclonal antibody. So ocrelizumab, ublituximab, ofatuzumab, all those things target CD20 B cells. So functionally speaking, very similar to CAR T in terms of its B cell target. However, notably, all these monoclonal antibodies work in the blood, in the periphery. They're not crossing over the blood-brain barrier and necessarily having effects there. Whereas in CAR T therapy, that has that potential and can reach those resident B cells in the brain. Additionally, when you look at studies that have looked at the depth of B-cell depletion in CAR T versus those monoclonal antibodies, again, think about those things, like I said, rituximab, ocrelizumab, ofatuzumab, all those mAbs that are targeting those B-cells. You get a greater depth of penetration and depletion using CAR T. And this is an example on the slide of a patient where they did a lymph node biopsy so this top row is pre-CAR T, the second row is post-CAR T, and in comparison, on the third row is post-rituximab. And everything brown in here is those CD19, CD20 cells that we're seeing. You can see after CAR T, they're completely wiped out. And when you compare that to using a monoclonal antibody like rituximab, you still have some resident B cells in that lymph node. So you're not completely getting rid of everything. Another way to look at it is, we could see this potential for depletion of resident B cells in the brain. So we know that CD19 and 20 B cells can get across the blood-brain barrier. We see these little clusters of B cell follicles in the brain, in the cortex. Ocrelizumab, rituximab, ofatuzumab, just using those as an example, those monoclonal antibodies they're too big to get across that blood-brain barrier. However, your CAR T cells can, and that gives you that potential for deeper tissue penetration, not only that we saw on the lymph node, but potentially in the brain, although those studies weren't done using brain biopsy. Lymph node biopsy is a lot kinder. But that is another theory of why this would potentially be a better option. There are lots of CAR T trials right now that are just either just opening up and just starting to recruit, mostly phase 1 with the exception of one phase 2, or at least on the docket of not yet recruiting but in process where they're looking at opening up. If you go to clinicaltrials.gov, this is where I took this from. This is across worldwide. So I put here on the slide, which I believe you'll have access to, some of these things are happening in China, but some of these things are happening right here in the US. And we have one that we're affiliated with here on campus, which is the first row here, that we are recruiting for relapsing remitting MS and primary progressive MS. Across the United States, there's also additional clinical trials ongoing, as you can see here on this slide. So let me get into what does this look like from a patient perspective. So if you're enrolling into one of these clinical trials, whether, this is what it looks like for all autoimmune disease, whether it's MS, stiff person syndrome, lupus, what does the CAR T process look like for the patient? Well, it first starts with blood collection. So you go, obviously there's consent and screening and making sure everything, you're healthy enough. But if you are considered a candidate, it starts with something called apheresis, where we collect your cells. So you're going to go in, think about it as almost a dialysis for your immune cells, where they're taking blood out, they're collecting your immune cells, you get blood back, and then those immune cells are going to go to the lab. And that is where your T cells are isolated. After your T cells are isolated in the lab, they will basically undergo a process where they have a genetic modification, meaning they need to put that CAR protein on the top of your T cell. So that way that T cell knows what its target is. It knows to target those misbehaving B cells and wipe them out. So that CAR flag is a CD19 CAR in most cases, but you can change it and have different targets. But for the majority of the studies that are ongoing for multiple sclerosis, it's a CAR that's targeting the CD19. And so once you get this protein flag on the outside of your T cells, and they use a viral vector in order to do so, just like that cartoon that I showed with the big T cell CAR T guy, then they will grow those T cells in the lab, so they're plentiful, and they will multiply them. These T cells then come back to us out of the lab, in which they're given back to the patient. Now, most of the current CAR T studies that I showed you include lymphodepletion. The lymphodepletion is something that primes your immune system so you're ready to receive those T cells back. And that most of the protocols that includes something called cyclophosphamide right now, which is like a small dose of chemotherapy. So you undergo the chemotherapy for a couple days, make sure your immune system is ready to receive those cells, and then you get admitted to the hospital where you get that T cell infusion, again, your own T cells that are going to target and get rid of those misbehaving B cells. This process does require, and every protocol might be slightly different, but in general, this process requires admission to the hospital, because we can see some bad side effects when your B cells are being destroyed, like that cytokine release syndrome. And so these protocols are tough. You need to be admitted to the hospital. Often that includes a 10-day observation after you get the infusion. And then after that, many of the protocols require that you be within a certain mile radius nearby, so you can have frequent check-ins for 28 days afterwards. These T cells then, or these B cells, once they're destroyed and killed off, the hope is that afterwards you will repopulate, because this is a one-time infusion, you will repopulate healthy B cells. And we don't want to see these new B cells producing autoimmune disease. So you can think of this almost as a reset to the immune system. And hopefully the Holy Grail, but the reason this is all being studied in clinical trials is because we don't know the answer, is that after this treatment, then you get nice healthy B cells, you reset the immune system, hopefully no more autoimmune disease, perhaps not even needing ongoing treatment like disease-modifying treatment or immune-suppressing medications. But that is yet to be seen. That is something that is actively being studied. And with that, I'd like to thank you.